Hi, everyone. I made sure to get myself off mute this morning. Hope you're all having a really good morning. I'm the Director of Strategy here at California Institute for Behavioral Health Solutions. I wanted to just give you an update about some new webinars that we're going to be offering towards the end of this series. It's part of our mission at CIBHS to assist providers to advance health equity through your own practices and behaviors. For this reason, we've updated our webinar series. The topics are going to help you support your clients through the public health crises of COVID-19, police brutality, and racism. On July 8th, we're going to offer a webinar that will provide tools and strategies to address implicit bias, which we all know undermines effective behavioral health services. On July 15th, we'll be sponsoring a panel of behavioral health providers who are offering telehealth in communities of color. We're going to be able to learn more from them about their strategies and their innovations to be effective in telehealth. What we'll do is that we will put the link for the CIBHS website so that if you'd like to register for either of these webinars and you haven't yet, you'd be able to go to our website to register. The information will also be in a post-webinar email that's going to come to you. Now I want to introduce you to today's presenter, Eric HARAM. Eric joined us previously in this webinar series. He worked with Elizabeth Morrison, did a fantastic kickoff webinar for us that focused on preparing for success in telehealth. We're really excited to have him back today, where he's going to focus on harm reduction in a virtual environment. He's a licensed alcohol and drug counselor, and he's the owner of HARAM Consulting, which is a health and behavioral health consulting firm. HARAM Consulting offers technical assistance for all aspects of strategic planning, workforce development, and clinical as well as business systems design for states, institutions, and organizations. Eric's professional experience includes 30 years of delivering, designing, and directing substance abuse treatment services. He's done this in hospitals, correctional facilities, and community behavioral health centers. As a national consultant, he provides expertise in 11 states, from California to West Virginia, including his home state of Maine. He also provides countless hours of advocacy for improved access to addiction and mental health treatment in the Maine state legislature. He was president and board chair of the Maine Association for Substance Abuse Programs from 2007 to 2013. Now I'm going to go ahead and turn the floor over to Eric to begin his presentation.
Thanks, Jennifer. So welcome, everyone. We're going to be talking about harm reduction in a virtual environment today. To do that, we're going to cover a broad range of topics. We're going to look at health equity, stigma, discrimination, racism, and the impact of these systematic problems on access, on health equity, on, in fact, patient outcomes and public safety overall. We'll talk a little bit about strategies to most effectively engage individuals who are actively using substances and struggling with other co-occurring health or mental health issues as well. And what counseling techniques can be used to be most respectful, most present at engaging individuals where they are. And then we'll finish up by talking about some teaching tools and some guidance on how to teach individuals who are continuing to actively use drugs and alcohol in harmful ways to reduce that harm and to use substances in safer methods. And that will take us to about 5 or 10 after the hour. So let's start by talking just a little bit about what is harm reduction. Really, harm reduction is a set of practical strategies aimed at reducing the negative consequences of drug use. It's also a movement of social justice built on the belief in and respect for the rights of individuals who are using drugs. That's a platform that is counterintuitive in our society, and in fact, one of the big drivers for stigma, discrimination, and in fact, racism as well. We have a long history of justifying poor responses, violent responses, disproportionate responses, inequitable responses under the guise of, well, they were drunk or they're a dealer. Those are policies and disparities that are going to have to be taken on by our field. And we're going to get into it, and it's going to be difficult, and it's nonetheless, it needs to happen. So let's go on to the next slide. So let's start by talking a little bit about stigma. So just digging into the Webster's dictionary, stigma is really defined as a mark of shame, a stain, an identifying mark or characteristic, especially a specific sign that indicates the presence of a disease. Now that's a very old definition. And nonetheless, when you unpack that, you can see pretty quickly how difficult it is for individuals to contend with conditions that are steeped in such heavy stigma in our society. Former director of the Center for Substance Abuse Treatment in HHS here in the US, Dr. Kim Johnson, in 2017 during a talk about stigma was pretty clear at saying, really, providers should be talking a lot less about stigma and more about discrimination and racism. Stigma is, in fact, I think one of the ways that we water down the real impact of what we're talking about here. Let's go to the next slide. So if we're going to define these things, stigma refers to negative stereotypes, an attribute, behavior, or condition that is socially discrediting. Discrimination is the behavior that results from the negative stereotype. And racism is the belief that different races possess different characteristics, abilities, or qualities so as to distinguish them as superior or inferior to one another. So if you just think about these three things, how quickly they feed one another, and all the more reason that we should be taking on racism in our field and equity around both access to behavioral services, harm reduction services, mental health services, as well as the role of public safety. And the absence of community policing. Let's look at the next slide. So all of this plays out in what we call implicit bias, right? Implicit bias are unconscious attitudes and stereotypes. We see on the news, on the internet, on social media feeds, just egregious examples of implicit bias playing out seemingly everywhere, and how this affects our understanding and our actions. And the problem here is that as humans, we're not very good at seeing this in ourselves. In those moments, it is our brain's ability and tendency to rationalize and justify what we are doing in the moment. Fortunately, we are much better at seeing implicit bias in other people. This is, in fact, why bringing these issues to the forefront in a transparent fashion and calling them out when we see them, holding each other accountable, are critical parts of moving forward with change. Now, one of the ways that we can illustrate this most simply is I've done a lot of work in the last year implementing medication-assisted treatment access in emergency departments. And we talk a lot about implicit bias in that clinical environment. When I do trainings with physicians around substance use disorder, particularly opiate use disorder and pharmacotherapy, I always start the training by asking how many of you, while you were in training in medical school and residency, we're really looking forward to matriculating and moving out into the field and working with active opiate use disorder and substance use disorders. And those of you in the behavioral health field wouldn't be surprised that no one ever raises their hand. Most folks don't go to medical school looking forward to working with folks with behavioral health disorders. And in fact, the system has been so stacked against these populations that is, in fact, one reason we're in the epidemic we're in around misuse and accidental overdose and overdose or suicides with opioids. So within that environment, we would see implicit bias play out. And one way that can play out is, for example, the individual presents to the emergency department in active withdrawal, having had Narcan administered from an overdose, and they begin to tee up the standard of care. And one individual might say to the person, "You made a good choice coming here today. These folks are really going to know how to help you." And you can see the direction that sets care on. Versus a different strategy where you would see someone's implicit bias play out, and they might say, "Gosh, you're not here for Suboxone, are you?" Right? Those are two different ways to tee up that standard, and one is intended to move someone on the pathway of health and wellness, and the other is intended to block the individual. And we would see those things play out, and that's why we would do so much training on implicit bias, to the point that in each staff meeting, we really recommend specific information about language, and that teams, clinical teams in the general medical community and the general community as in general, practice new language, hold each other accountable, and take opportunities to be transparent about what their struggle is with certain populations. Let's look at the next slide. So stigma can be broken down into a number of different areas. We're going to look here at institutional and social stigma. Institutional stigma is structural practices, intended or unintended, that restrict certain individuals or groups from community or governmental opportunities based upon policies, practices, and tradition. And the disapproval of or discrimination against a person based on perceivable characteristics that serve to distinguish them from other members of a society. I use, substance use, chronic alcoholism, opiate use disorder as examples of, if you look at our history in the field, we've known since 2002, 2003 that access to medications approved by the FDA for the treatment of opiate use disorder is the gold standard of care for this population. And within the field of substance use disorder treatment in general, we're now 17, 18 years past that understanding. And we're still heavily working on expanding access to medications for addiction treatment in the publicly funded and state-funded safety nets of contracted providers. There are still more contracted providers in the field that do not offer this service than there are who do. That's institutional stigma at play. And that blocks an entire population from accessing a service we know to be the most effective. Okay, that's a structural practice. Let's look at the next slide. And so, of course, this plays out in an internal fashion, right? And that's what we call self-stigma. Self-stigma results in part from public stigma in a process leading to internalization of the negative stereotypes associated with a given condition. Right? And this is, in fact, why it's so difficult for people to ask for help. The identified person, the person struggling with substance use, as well as the people who care about that individual. Family members, as you well know, experience a great deal of stigma about someone they love who struggles with behavioral health issues, mental health disorders, substance use disorders. which of course compounds the self-stigma that the individual feels. And so you can start to see the layering of the impact of social stigma, of implicit bias, of how those things block and serve to reduce access to equitable standard care. And that then gets exploited further into discriminating whole populations and playing out in hierarchical and racist fashions. So let's look at this next slide. So these are some quotes. These are things that I know everyone has heard. And the best way that I can think of to put ourselves in the shoes as best we can of what it's like to be dealing with these problems with this level of discrimination and racism that ultimately interact with systems and can only distort both individual outcomes and public health overall, right? And so moving down this continuum, we hear people say things like, I struggle with people offering me help. I still don't think that I'm worthy of it, right? That's just a clear example of self-stigma. Once we start something good, we feel guilty because we feel like we don't deserve it. Or moving to systems, structural stigma and discrimination. They don't care about me there. Why would I possibly show up? The last time I went to the emergency department for help, I sat for hours. Everyone was rude, and police and security kept asking me why I was there. Okay. And lastly, when we just play this out in terms of blatant racism, right? And working in the field for 30 years, I haven't always lived in Maine, and I've had the pleasure of working and running programs all around the country. And working with clients who we started our relationship under the pretense that everything was fine. And though I am a stranger, you're the counselor and you're going to help me. And quickly arriving at multi-generational protections around coping with inequities and racism. Don't tell white people your business. You've been seeing this all over the place these last months. These messages, you know, keep your hands out of your pocket. Ask permission to show your ID card. Don't wear this outfit. Don't wear that outfit. How you present has a lot to do with your safety and the outcome. Right? Are you going to jail, or are you having a diversion and going to drug court? Well, that depends on the city and state in our country, and it varies greatly, as you all know. But you can see how these kinds of statements distort the work that we're intending to do. Right? They front load these relationships in ways that make it very, very difficult for engagement, for retention, and for meeting a person where they are. And first and foremost, that's our job. That's our mission. Next slide. So really one of the first pillars of health equity is equitable access to resources and services. And the reason we're talking about harm reduction in particular today is this is a full portion of the overall continuum of care. And in the treatment industry, by and large, we've not done a good job at embracing harm reduction as really valuable and bona fide partners, of viewing all of these resources and services not as polarized philosophies of care, but as parts of a whole continuum. that people can access and move in and out of, right? And ultimately, the general rule of thumb is that people can't get help if they can't get in. And nationally, this is a huge problem. And COVID and social distancing and many of us moving away from face-to-face care to telehealth on the phone or video has made the problem worse, right? And so treatment really begins with the first contact. The first contacts in most SUD programs have with those seeking help sets the tone, for show rates, engagement, and retention in the future, and ultimately outcomes. That very first contact. Most processes directly dealing with initial engagement are operationally designed more to comport with regulations and financial obligations than they are finding your customer where they are, finding that person and meeting them where they are. Often these are not designed with the client experience as the driver or at the center. Again, they're viewed at which T's do we have to have crossed, which I's need to be dotted, how do we drop a bill, as opposed to, again, why are you reaching out today and how can we help you? Right? In behavioral health services, we often find poor integration of clinical and operational front-end processes as a major internal barrier to both clinical and business improvements. The field is traditionally polarized, where we have operations directors and clinical directors, and they don't often meet until one strategy conflicts with the other, right? And increasingly in our field, we're finding that there are individuals who have great talent in both of those arenas, and those are individuals to find and nurture. Folks who understand how operations work through a clinical lens can really do a great job with these kinds of systems design. Next slide. So access and front-end processes. So thinking about this from the client perspective, and there are some universal truths here to bear in mind, right? And these are just basics of customer service. The steps we take from the first contact through the end of the first clinical encounter make or break a prospective patient's resolve to attend and return. No one aspires to attend an evaluation or treatment. Nobody woke up one day and thought, you know, I'd like to acquire a chronic substance or mental health condition that requires intervention and care. Right. The many steps in the road to recovery are not palatable on the first contact or appointment. Right? We don't have to lay out every single thing that we think is going to occur for a person in that initial contact. Right? What is the person looking for? Where are they now? And how can you provide some hopeful relief in this initial contact? Right? And to that regard, rules and lists at initial points of contact are in fact distracting from the intent of the call or the person reaching out. Okay. One of the things I do in my consulting work is do assessments and evaluations of programs intake and access systems. When I hear an individual call and say, you know, I've got a problem and I need some help, and this plays out particularly with opiate use disorder, and the person may call and say, I heard you prescribe Suboxone there, so I'm calling. Right? That's a sign of a person gravitating towards health and wellness. Right? And so what we want to do in that circumstance is that's change talk. We listened for it and we're going to acknowledge it and validate it. Right? When all these things have been kind of going wrong in your world, you made a great choice calling today. We know what to do and we're going to be able to help you. Right? Versus, oh, you're calling for Suboxone. Well, let me tell you, there's some things you need to know about that first. Right? You're going to have to come to treatment. You're going to need to be in the groups. You have to agree to, right? And they start laying out all of the kinds of things to make sure that you're really motivated. That's the opposite of a low demand characteristic, right? Again, I'll say it again, rules and lists at the initial point of contact are distracting from the intent of the person calling you. We rarely remember what we are asked in service access, but we always remember how long we waited and if the person we interacted with was nice. Right? Think about the last time, goodness, now with COVID, that's a little different, but think about the last time you went to a medical appointment. And maybe there were some pre-screening questions, or you know, you had the whole family history to fill out. We don't typically remember, oh, they asked me this, they asked me that. We do remember, I sat there forever, 45 minutes waiting for them to come in after the medical assistant did the rooming, right? And I didn't get a chance to talk about what I came here to talk about. Right? Again, these are just tenets of basic customer service. You do not have to be a behavioral health expert to hold these universal truths in your interactions with clients. Next slide. So really the pillar here behind why we're talking so much about access is that across our country, roughly only 11.5% of people who want and need addiction treatment actually can obtain it. Right? From front end or access processes contribute heavily to engagement or show rates. The processes are defined as either high demand or low demand characteristics. So again, we're talking about a system, we're talking about a design or a workflow. And that workflow either has high demand on customers or low. And the best way I can describe that is I did a speaking engagement with an individual who's in long-term recovery, and they said, you know, my dealer delivers, right? I could text him and he'd come over, and made it really, really accessible and easy. Trying to find treatment was hell, was extremely difficult. And if it's going to take me 2 or 3 hours on Google and a telephone or a Zoom video to try to get an initial appointment, I could have scored by that and been high and been off and running and not worried about it, right? And we need to really think about our business in those simplistic terms, right? Is it easier to get help than it is to get into some trouble? And right now, the answer to that is no, it's not. I did a recent walkthrough where I played the part of a patient and I tried to access treatment services from one of my clients. And just, you know, Googling that as an initial place to start. I was fished and I was taken all over the country. And frankly, into standards of care that you cannot reconcile with today's literature. And there were lots of individuals that were willing to help me if I was willing to go out of state, pay out of pocket, and maybe go live in a sober house, $300–400 a month, while I paid $1,000 a week for IOP. On top of that, that's not the level of care I was looking for, and frankly, not the level of care I needed. This is a real problem in our country. Next slide. So let's look at these. Let's break it down in terms of examples of high demand characteristics for access and low. If we're talking about high demand, we're going to have to leave a message. We don't actually talk to a human when we call. Or maybe we're through a multi-button auto attendant. Maybe we're placed on hold for a period of time. We're told we need to bring proof of income and ID. And a lot of times those are in the first 3 questions. Waiting lists. Waiting lists are the antithesis of low demand characteristics, right? in all of the programs and services that I direct and run, we immediately, one of the first things we do is we say, we have a new policy. There is never a waiting list here. And everybody looks at me like I'm insane. Well, how can you do that? What if we have 12 people in the group? We'll be overrun. What if we don't have enough staff, right? And so what we're doing here is we're changing the paradigm. Is we're taking waiting lists off the table as a solution to managing throughput and volume, right? Being on a wait list is not helpful. We're in the business of helping. So how do we design policies and systems and workflows that are helpful instead of unhelpful? And from a purchasing standpoint, if you are a county or state purchaser, this is a policy that I would strongly encourage you to look at. First and foremost, there's a lot of changes coming down in the coming years. This might be one of the ones that you think about as a priority, right? Is, wow, in our funded system, we're going to figure out how to not run wait lists anymore. There'll be no more sitting on someone's steno pad, and if you don't call once a week, you fall off of it. Again, the first tenet of getting help is to be enrolled in it. Again, reviewing rules for participation at the initial contact, multiple contacts prior to disposition, administrative process delays in care, and just straight up discrimination, stigma, and racism that are in fact high demand characteristics to accessing services. I have personally witnessed these kinds of egregious blocks, right? And they can play out in subtle, covert, or blatant and overt ways. So if we look at low demand characteristics, this is when in real time a person, a total human, answers the phone and speaks to you. There is a clinical triage, not a financial triage. There is low or no wait times, meaning the first encounter can occur within 72 hours of the initial point of contact. Same day or next day is best. We're only providing what's tolerable, right? We're not asking people to do things that they are unable or unwilling to do. We are available to troubleshoot barriers, things like transportation, childcare, access to medication, benefits or entitlements, right? And there's the availability of FDA-approved medications for addiction treatment. And in fact, what we'll talk about a little bit further in the slide deck is that there is a medications first process, meaning that there's a priority to quell the individual's withdrawal, preoccupation, and craving. Next slide. So in terms of thinking through, what are some strategies for lower front-end demand characteristics? And these are, in fact, quality improvement projects, and highly recommend that you play the part of a client trying to access services from your organization. Pick a character sketch that should be a slam dunk admission to one of your services, and then try to get it. Watching waiting teaches us a lot. Right? And so some of the things that we work on to make improvements to client access are reducing wait times from initial contact to first encounter, streamlining paperwork, improving real-time phone answering and scheduling, right? Not having to call people back with their appointment date and time, being able to do that in the first encounter. All of these things, frankly, can have a byproduct of increasing volumes and admissions. right? When it's easier to get in, it's easier to get in. More people then will, right? In some of these programs and systems where we've really had to work hard on removing high demand characteristics and moving to lower demand characteristics, what we found was there was a lot of clients who were perfectly appropriate for the varying services in that continuum who were just not being able to get in. Right? And oftentimes individuals that were insured or funded or had some mechanism to be able to cover the cost. We want to review and adapt policies which restrict access goals. Right? These are things like readmission rules, relapse policies, and evidence-based practices to monitor performance. Let's look at the next slide. So a significant part of this, right, as we've been talking about access, has been how are we talking to people, right? And all of these contacts, whether you are a first responder or whether you're a general medical professional or you are a outreach worker or you're a counselor or a therapist, right? All of these interactions can be defined as opportunities for brief interventions. And really the best way to improve these brief interventions and interactions is to really be comfortable and using motivational interviewing techniques. Right? And so if we define brief interventions, they are opportunistic interventions which are short, virtual or face-to-face conversations regarding a risk-oriented behavior, motivations for change, and options for change, which are provided during this window of opportunity or potentially teachable moment. These can often be occasioned by a medical event. Right? Brief interventions are when the opportunity arises. Brief interventions are successful when clinicians relate a person's risky behavior to what the person sees as the issue. Right? And so when those windows of opportunity open, it's because the person has something that in that moment they're worried about and they want to do something about it. If you take the focus away from that to your agenda, you're most of the time you're going to lose that person. Next slide. So this is really a shift in our thinking from why isn't this person motivated to for what are they motivated. Next slide. So if we look at this, in a simple flow chart or algorithm, you have a presenting problem. We render some kind of typical screening around that. And then we begin to explore awareness of that problem based upon those screening results. That if we are being adherent with motivational interviewing and interacting in the spirit of motivational interviewing, right, we're going to be looking for the person's motivation. We're going to be trying to elicit for what are they motivated, right, with the goal towards reducing risk from that particular area. Next slide. So brief interventions for person at risk due to substance use specifically, and let's jump into this. Next slide. So one of the things that the folks behind motivational interviewing are great at is these acronyms to help us remember. Right? Whenever we're learning a new technique or theory, it can get a little clunky because we're thinking about the words in real time. Right? And so these acronyms can help us with not being as clunky when we're first starting. And so FRAMES is one of these things, right? And that's where we're remembering we're going to provide some personalized feedback. We're going to be looking at responsibility, asking if we can provide some advice around a menu of options that is conveyed with empathy and designed to elicit self-efficacy from that person. Phrases. So next slide. So the reason we're talking about brief interventions is because within the tenets of harm reduction, right, there are these opportunities where the window opens and we can have a conversation with somebody that might help elicit some change talk and move them along the continuum to some resources that reduce their risk and reduce harm, right? And we learned this really in inpatient settings where we taught floor nurses motivational interviewing in pretty large, busy detox centers. Recognizing that most of the interactions that the floor nurses had with those patients were 5 minutes or less. And over the course of an entire shift, right, rarely added up to much more than 20 or 30 minutes overall. And the way that they spoke to those patients, the ways that they elicited change talk, validated feelings of ambivalence, and improved actually meeting people where they were. There was noticeable improvements in the milieu, in behavioral interactions, and clients' ability to be able to be more open, right, with what's going on and what they needed, and particularly because of these detox facilities, next steps following a brief inpatient detox stay, right? We recognize that detox alone for chronic alcoholism and opioid use disorder has a very high 80 or higher % relapse rate when detox alone is the only standard of care provided. Next steps and transitions of care are usually important, and in fact, why we were talking about this as a continuum to begin with. Next slide. So where do I start, right? What you do depends on where the person is in the process of change. The first step is to be able to identify where the person's coming from, and people are better persuaded by the reasons they themselves discover than those that come into the minds of others, right? And you can sort of be creative with this. You know, one of the things that I say to clients sometimes to help elicit some change talk is, oh, when you said that, you just put the best idea in my head, right? And it's a way of kind of nudging as you move the person along this continuum. Next slide. So ultimately, what this is about is identifying ambivalence. Ambivalence is a normal state of being when any of us are contemplating some type of change. Right? All change contains an element of ambivalence. We want to change and we don't want to change. We talk about, I feel two ways about this. And in fact, people's ambivalence about change is at the very heart of your brief intervention. Next slide. Reflective listening is how we find that ambivalence, is how we hear and anchor on to pieces of change talk, right? Listen to both what the client says and to what they mean. Showing empathy and not judging. You don't have to agree to show empathy and be non-judgmental, right? Be aware of your intonation and your body language. Reflect what people say with statements, not questions, right? You couldn't get up for work in the morning. Right, and you can sort of put an ellipsis at the end of that because that's going to elicit some discussion. Next slide. So open-ended inquiries, right? Request a story, tell me about, help me understand. What would it be like if, right? Those are open-ended questions versus closed questions, right? That are going to give a one-word answer. You're not one of those people that uses cannabis, are you? No. Right? You're not going to get much change talk or be able to prospect a person's ambivalence about a change when you stack the deck with closed questions. Next slide. So another one of those acronyms, FLOW, right, which stands for feedback, listening and understanding, and options explored. I like this one better than frames because I don't remember that many letters. I can do 3, but not 5. And the W in flow is not supposed to be there because you should not be warning people, right? You should be providing some feedback based upon standards and what you hear. You should be using reflective listening to convey your understanding of where the individual is and what they are motivated for, and then exploring options with them. Next slide. So if you put this all together, right, you've got feedback. What you're doing, and can I offer some feedback here, is you're setting the stage, right? Maybe you've administered some kind of standard screening tool, and that is what you're going to provide some facts about. Following that, you're into your classic Rogerian listen and understand, exploring the pros and cons, explaining the importance, and assessing their readiness for engagement in a change. And then lastly, exploring options, discussing those change options and making follow-ups. I am seeing on the chat that somebody has written, we've had a rather strong earthquake and we may lose connection. I hope everyone is okay. Hang in there. Next slide. So the 3 tasks of brief intervention. So let's take on feedback. And we're going to roll through these 3 areas pretty quickly. Next slide. So rolling with resistance, right? This is just a part of the deal. And when we talk about people having ambivalence or feeling 2 ways about a change, you're going to get some resistance, right? That's a part of it. Look, I don't have a drug problem. My dad was an alcoholic. I'm not like him. I can quit whenever I want. I just like the taste. Everybody does this in college. Why should I agree to change any of this? Right? Those are classic resistance statements and thinking about what you say and how you respond. Right? Again, next slide. Our response to those is in the spirit of motivational interviewing, right? Open-ended questions. We're not going to say, what is wrong with you? How can you not see it? It's right in front of your face. When you use, bad things happen. Right? Those, in fact, may be factual, but they're just not helpful in this moment, in this brief opportunity. Right? I'm not going to push you to change anything you don't want to change. I'd just like to give you some information and some facts. What you do with this is up to you. Next slide. So I'll say one of the things that we do in staff meetings is what I call batting cages, right? And what a batting cage is, if you've been around in the field of substance abuse counseling and public outreach and harm reduction for a while, you're pretty used to resistance statements. Being comfortable in your response to those takes practice. Right, and so we do these things in staff meetings sometimes, a couple times a month, where we call them batting cages. And I'll play the part of a client, and I'll just start throwing out resistance statements. And we go around the room, and each staff person says something that is motivationally adherent, right, in the spirit of motivational interviewing, and they respond in a way to roll with that resistance. In that way, we get more comfortable with it, right? And it becomes more natural. Next slide. So when we talk about listening and understanding, we're trying to find the person's ambivalence, right? We're listening for change talk. Maybe drinking did play a role in what happened. Maybe if I wasn't drinking, this wouldn't have happened. Maybe using is like that is just not as much fun as it used to be anymore. Can't afford to be in this mess again, right? The last thing I wanted to do was hurt anybody. Well, I've been successful stopping before, right? So those are all examples of change talk. And listen and understand. Understand part means that you convey back to them that you get what they're saying, right? Summarize it, say it twice so that they hear it. Next slide. So one of the ways that you can do this is the fancy term for this is a conviction and confidence interval. Otherwise, it's on a scale of 1 to 10. We use this as a very, very fast way to assess really where a person's at, right? In terms of the importance of this change to them, their readiness to make it, and their confidence that they can be successful. So on a scale of 1 to 10, how important is it for you to change your drinking? On a scale of 1 to 10, how confident are you that you can make that change? And how ready are you? Right? One of the ways that we elicit change talk with this is, let's say the person says on a scale of 1 to 10, I'm a 6 in terms of my readiness to address this drinking. Right, and so we want them to be talking about the side that's weighted towards change versus the side that's not. So we would ask, wow, a 6, that says you're pretty ready. How come a 6 and not a 2 or a 3? Right, and in that way, you've asked them this open-ended question to set them up to talk about the side that's more engaged in change than not. Okay? And those are simple, and they take 3 to 5 minutes. Again, we're talking about brief opportunities. The other thing that these conviction confidence can tell you is when there's incongruity, right? On a scale of 1 to 10, in terms of importance to make this change, it's a 2. In terms of my confidence, it's a 10. In terms of my readiness, it's a 2. What that person just told you is, I don't want to change right now. Right? It's not important to me. It's only a 2 on a scale of 1 to 10. My readiness is a 2, which means I'm telling you I'm not really going to do much about this. And if I wanted to, I absolutely could be successful, right? Even though you get some incongruity there, and maybe those aren't the results you were hoping for, that incongruity is where ambivalence lives, right? They've actually given you a very rich playing field to prospect with them some change talk. Next slide. And next slide. So the third task is where we're going to be exploring options, right? What now? What do you think you're going to do? What changes are you thinking about making? What do you see as your options? Where do you think we should go from here? What happens next, right? These are all segues into options for change. So let's look at this next slide. So offering an option of menu of options for change. One of the things it seems like we forget in our field is that our clients may not know exactly what they need. Right? As professionals, it's really our job to kind of meet people where they are, assess them while keeping, of course, respect and dignity intact, and building a menu for them that, in fact, has value and is indeed matching their focus, right? Their interests. We spend all that time eliciting the discussion from them. Now we have to put together a menu that is real, right? And so some of those things may be, maybe you want to cut down your use Maybe you want to think about lower risk limits. Maybe you want to think about resources for safer drug use, accessing needle exchange, understanding how to clean your works, making sure that people have access to Narcan. Maybe the person wants to quit completely. Maybe this is just focused around certain kinds of harmful behaviors, such as driving while intoxicated. Maybe they don't want to do anything at all. Or maybe they want to explore further through some broader evaluation, right? And so one way or the other, a menu of options, by virtue of the word menu, means there are a number of things for the customer to consider, right? You need to go to detox and then to the residential program. When the client just said, I don't have insurance, I'm a single parent, I have young children, and we don't have transportation, and I'm currently not working, right? We didn't, when our menu of options is only one flavor that the person has explained they are going to be unable to access, that's not a menu of options. It's the same thing as saying, I'm sorry, we can't help you. Okay, next slide. So the last thing here is really sewing up the conversation, right? Summarizing your client's views, encouraging them to continue to share them, and summarizing what agreement had been reached and repeating it. Next slide. So we always want to encourage follow-up. Whatever environment you're having this brief window of opportunity for an intervention or a discussion, you want to have the person come back somehow, right? And so at follow-ups, we want to inquire about their use, review any goals and progress. We want to explore their continued motivation, ambivalence and change talk, and reinforce all of those items gravitating towards health and wellness. And we want to review tips for progress, right? These are the things that are going to keep the person engaged and moving towards healthier behaviors. Next slide. So let's get into some of the tools here and guidance where we talk about really teaching our clients, our customers, how to be safer when they're actively using drugs, particularly right now during COVID-19, the pandemic, and all of the ripple effects of that have made equitable access to help even more constrained. Right. So again, COVID-19 and the harms to people who use drugs. One, the war on drugs policies have been fueled by racism and xenophobia. Many people have chronic medical conditions that go unaddressed that are risk factors for COVID. Stigma, distrust, fear, and alienation from healthcare systems. One of the small hospitals I'm associated with here in southern Maine, if we go back to April, volumes coming into the hospital for all the types of things people come into the hospital almost completely dried up. Individuals were coming for testing, for symptoms of what they thought was COVID, and in this particular general hospital, they do admit individuals to the med-surg floor who need inpatient detoxification. So it was really alcohol detox and direct COVID-related clients that were the only people coming to the hospital. And there was a resurgence. We've done a lot of work on training around stigma and discrimination and access, and there was a resurgence of that old implicit bias, right? I heard from attendings in the ED and the hospitalists, why are these people coming in here? Don't they know we have, COVID and all this other stuff to deal with? Nonetheless, an alcohol withdrawal syndrome is an acute presentation. People can die, and if they are assessed as meeting inpatient level of care, they ought to be able to access it because that's in fact standard. Criminalization of people who use drugs and or live in poverty, housing insecurity and homelessness that includes nutrition and sleep, lack of means to enact COVID-19 prevention measures, and living in everyday state of emergency and structural violence. Right? This is baseline. And now we have our pandemic that we're all coping with. Next slide. So we need to be thinking about overdose prevention really first and foremost, right? Using universal precautions, especially regarding changing sources and using alone. We want to encourage people to stock up on substances and be prepared for possible withdrawal, right? And that includes alcohol, benzodiazepines, and opioids. Re-envisioning safety planning during physical distancing. If not physically together, try and utilize other tools, right? Video, calls, FaceTime, hotlines, the Never Use Alone hotline, mutual aid networks, encouraging you to create local ones as these national ones become constrained. Right? What will you do if someone does not respond? Options if EMS or paramedics are unable to respond. So certainly access to Narcan. Again here, next slide. So I love this. This is New York State's Department of Health example of a safety plan, right? And rather than going through this in detail, I want to direct you to the handouts. We've included breakdowns of each of these categories as a part of this comprehensive plan. Right, and so there are things like build a plan, know the facts, carry Narcan, find a buddy, talk about your use, right? Write down what your safety plan is, know where helpful resources are, okay? Next slide. So we also all need to be thinking about our overdose response, right? Check responsiveness, how to access and administer naloxone, ways in which we can alert EMS. Do we know rescue breathing and CPR? Are we aware of the recovery position and aftercare services following an overdose? And so I think my next slide here, we're going to look at some resources around that. Right. The DEA has changed their guidance regarding prescribing and dispensing methadone and buprenorphine during COVID. Telemedicine is permitted for initial visits as well as regular visits, and controlled substances such as Schedule III buprenorphine can be prescribed over televideo or phone with a new unestablished patient. Okay. You no longer have to have a face-to-face encounter first. This can be done via FaceTime, Skype, or any other video method. They are waiving HIPAA enforcement at this time. Next slide. So I mentioned earlier in the presentation, we've done a fair amount of work with implementing access to medications for opiate use disorder in the emergency departments, right? And this just gives you an example of pretty how simple the algorithm is, when an individual comes into the ED and we administer the clinical opiate withdrawal scale, right? The standard of care really has two pathways. Is their withdrawal equal to or greater than 8, in which case we are moving towards, most simply put, induction, or is the individual's withdrawal scale equal to or less than 7, in which case we may not be starting buprenorphine at that time, but evaluating for another hour or two to see if the withdrawal scales go or administering non-buprenorphine withdrawal management strategies. The reason this particular flow here works, next slide, is when that particular emergency department implemented their initiating buprenorphine in the ED, they did it with a predetermined behavioral health partner. In this case, it's called AMHC, which stands for Aroostook Mental Health Center, which is the entire northern part of our state of Maine. And so those 4 emergency departments had a bona fide memorandum of understanding and a workflow that guaranteed that every single person they started on buprenorphine in the emergency department could be handed off within the 72-hour window to this program and its prescribers. It has been very effective. In fact, since these folks have implemented, all of the patients that have been started on buprenorphine in ED have made their initial handoff appointment at this community prescribing partner. Next slide. So another way to think about this is the state of Missouri, who used their state opiate response money, really doing a pretty robust and heavily harm reduction oriented strategy called medication first model for the treatment of opiate use disorder. And the medication first, or low barrier maintenance to pharmacotherapy approach, is based on a broad scientific consensus that the epidemic of fatal accidental poisonings or overdose is one of the most urgent public health crises of our lifetime. Increasing access to buprenorphine and methadone is the most effective way to reverse overdose death rate. Increased treatment access will best be achieved by integrating buprenorphine induction, stabilization, and maintenance, as well as referral through specialty addiction programs and primary care clinics and other medical settings throughout mainstream healthcare system. Next slide. Really, the 4 principles of a medication first model is: 1, people with opiate use disorder receive pharmacotherapy treatment as quickly as possible prior to lengthy assessments or treatment planning. Now, these leniencies in our ability to assess and prescribe over the phone or video really are structural things that promote these kinds of principles. Number 2, maintenance pharmacotherapy is delivered without arbitrary taping or time limits. Individualized psychosocial services are continually offered but not required as a condition of ongoing pharmacotherapy, and pharmacotherapy is discontinued only if it is worsening the person's condition. Next slide. So we need people to be taught how to prepare for possible withdrawal, right? Call your doctor and ask if there are any medications that can prescribe to treat withdrawal. Buy and stock up on over-the-counters to treat withdrawal symptoms. Call doctor or an urgent care hotline about any symptoms you may be having before you go to the emergency room. That's an important thing. But do not avoid going to the emergency room. Right? There's a balance here. We do need to take care of our health and wellness. Checking in on the status, triaging your symptoms as either being COVID-related or not is an important part of today's puzzle. Next slide. So SSPs and best practice, right? Prioritize staff and program safety, participant safety, take stock of your essential services, review and create a communication plan, plan for employee absences, offer extra supplies, pre-package supplies for participants, and we've got to keep calm. Okay, next slide. So I think this is a really nice guidance pictograph here that is really clear on how to clean your syringes. Having this widely available for our folks is crucial. Next slide. So really, and then we've got to be, we'd be remiss if we wouldn't talk about the impact of COVID-19 and sex work, right? Risks are highest being close to someone with COVID for greater than 10 minutes. COVID-19 has not been detected in semen or vaginal secretions, however, has been detected in feces and blood. Use barriers as much as possible. If possible, avoid kissing and close face-to-face contact. Engage your regular clients as much as possible. If you can say no to someone who looks or sounds ill, please do. Wash your hands and shower before and after each booking, and access digital platforms wherever possible. Right, staying safer during this time is crucial. These guidances and teaching tools are very important for our clients. And I think this is our last slide, and so I'm going to turn this back over to Jen, and we can get into our Q&A.
I'm going to start off with a question that has to do with recommendations to support someone with harm reduction seeking counseling who feels they're not worthy of the care and other people need care more. This questioner was a mental health consultant within the schools, and they're working with a person who's had negative experiences in the past with therapists. So do you have any ideas about how you would respond to that?
I think, how do I put this? I would want to take a very strong trauma focus in those interactions. And I, in fact, would say to the person, you know, it sounds like you've had some really bad experiences. How can we put together a menu of resources that you feel most safe, that further, regardless of whether you feel you are worth this in the moment, let's start by saying you've done a great thing for yourself today in that you told me that, right? That must have been really, really hard for you. And I take that seriously, and as a compliment that you felt comfortable enough to tell me that. So how do you suppose we could think about next steps for you that you'd be willing to risk trying, right? I mean, I think I would just, again, with a pretty soft, maybe kind of a backdoor approach, elicit from the person a little bit of the trauma that is front-loading their choices, and see if we can't coax something there. Bearing in mind that if the person still refuses, what I'm going to do is say, you know what, that's okay. I'm not going anywhere. We're going to have this follow-up, and we'll continue to talk about this. I'm not going anywhere, right? If there's nothing else, you know, my sustained availability is something, right? And they wouldn't have told me that if there wasn't a willingness to come back. So that's how I would respond to that. That's a tough question because you sort of have to kind of simulate the counseling.
Right, exactly. Thanks so much, Eric. Another question, one of our participants really appreciated all the information that was provided. They wanted to know if you had specific strategies for actually implementing some of these great ideas that you had in telehealth.
Yes, and I would say, you know, sort of the first thing is I really encourage you, you know, simply do the walkthrough. If you're an administrator or a clinical leader, grab some random initial screen from a first caller, play the part of that client, and take notes. What's it like to find your organization's contact information? Were you on the phone? Were you on video? Did they explain to you this new technology? Right? You have to really walk through that and experience it through your customer's lens, then get together with your team and prioritize what you're going to address first, second, and third. These are difficult times, and we have only finite amount of energy and resources. So picking what is going to give you your biggest bang for your effort, where's your biggest improvement going to come from? I would really come back to examine your waitlist policy and examine your relapse policy. Right? Those are the two biggest things that block people from accessing services and remove people once they're in them. I'm frequently shocked how many organizations run waiting lists as a routine part of practice. And two, when you ask what's your organization's policy on relapse, don't actually have one. And so those are the two areas I would suggest starting. And you've got to be looking at this through your client's health equity lens. Okay, if you start in those two areas first with your population, I think you will get the biggest return on that effort.
Excellent. And this is actually kind of a follow-up, Eric, to where you just left off. For some of our folks, this came up with two different people, actually. They feel like their access issues are really due to legal and financial requirements that have been put on them that they can't work around. They feel like they've gone to their supervisors and asked for administrators, asked for more staff, and they're having a hard time financially justifying it, particularly during COVID when some staff really are down in their time. Any ideas about how to really kind of work through kind of red tape that gets in the way of access issues that can feel, to individuals in a provider organization as, something, a barrier that they can't move?
Yeah. Well, yeah, there's a number of things. The first thing that I would want to do in that circumstance is isolate that particular workflow that the folks asking those questions about. What is the access workflow, step 1, 2, 3, 4, and flow chart it, right? Put it on a piece of paper and get a small group of people together to identify all of the detail in terms of all the steps that are applied as the client moves through that workflow. And invariably, I call those, once we get it all down on paper, we call them a slash party, because what we're going to do is we're going to remove all of the superfluous things. Right? In our field, there's also a lot of mythology. And as we get people together and we start to examine a process at that level of detail, we find, I almost always find things like old and outdated forms. Wait, that's an assessment.
That somehow never get removed.
We retired that in 2013. We keep circulating these things. And I want to say during COVID particularly, there are so many leniences available right now relative to the standard intake paperwork that if we're not taking advantage of those now, we ought to, because you can't. So this would be the time to get familiar with those Medicaid chapter waivers, the specific leniencies and waivers in your state, and begin to change your staff's workflows so that they are not encumbered by paperwork they don't have to do right now.
Excellent. Great responses. I've had a lot of experience with those retired forms that somehow they always come back around. Okay, this is the final question for today, Eric. There was, when you were talking in motivational interviewing about identifying where your client is coming from, can you kind of talk a little bit more, explain what you mean by that phrase?
Where the client's coming from?
Mm-hmm.
Yeah, I think that's just classically, for what is this person motivated? in the field of behavioral counseling, we hear a lot of similar stories and themes, and it's very easy for us to get ahead of our clients, right? Of say, oh yeah, okay, I know where you're going. What you want to do is, and that's not adherent or meeting the spirit of motivational interviewing, right? When I decide I know where we're going in the clinical discussion before you tell me, um, I'm actually potentially blocking further engagement with this particular person, right? We're going to eventually arrive at a place where I expose that I have not heard them. And what happens to me when I tell somebody what I need and they reflect back to me something completely different is I don't talk to them again, right? I don't come back. So I think that's the best way I would respond to that.
Excellent. So Eric, we are at our time. For folks on the call, I know that there were more questions that we weren't able to get to. So just a reminder that what we do at the end of our webinars is that we collect all the questions, we send them to Eric, and he gives written answers. And so we will be posting those to the website, and we send out a message when they're posted. So Eric, thank you so much. I really appreciate you being here. Really want to thank the California Healthcare Foundation. So thank you so much. And these are incredibly challenging times for all of us. And so I just really want to thank all of you for taking the time to be with us today on this webinar.